Everyone that's in this hospital, think about that they're having the worst day of their lives. And when you don't put emphasis on, emptying out a bed so someone can occupy it, then, the workflow just kind of stays stagnant.
And so when this backup occurs in the ER and the PACU and everywhere else in the hospital, even ICU, PCU, and med-surg, we have no room for flow for patients that are coming in.
Meanwhile, that patient upstairs that was occupying the bed could be going home, but we didn't have everything in place for that patient to go home.
Because you may need insurance authorization to get that accomplished. It may not be safe for someone to go home without the equipment that they need.
But that would mean a doctor would have to visit that day, they would get assessed, and then they're more than likely to go home at the very end of the day.
It's a domino effect through the whole hospital because it starts on the floor and then it kind of trickles all the way down through everybody from the nurses to the cleaning staff to the emergency room to the OR to the PACU. Everybody's affected by this.
So the families are stressed out, the patients are upset, sometimes even the surgeons, the doctors are upset, their patients are waiting a long time to get a bed.
So just planning ahead and just looking at how you move patients appropriately and safely around in the hospital, it has helped tremendously.
Patient flow is really pre-planning the discharge, and the time is important, so it's supposed to be before 11 in the morning.
So the team got together and we started working on a plan for this, and it involved the entire care team. So step one was developing an SOP. The SOP was great. It had even a color scheme, so you knew exactly how your role related to the SOP. And then we started educating the inpatient staff.
There had to be a lot of buy-in from everybody involved to even set the project in motion, and then to roll it out to have everybody, on board.
We always pick at least 2 VIDAs the night before, just in case that one of the VIDAs falls through. We are able to work on getting the other patient out so that we can always ensure that at least one patient is leaving before 11 o'clock.
That way the night shift knows, then the day shift knows the following day who that particular patient is that's supposed to go home early. As soon as the doctors start rounding, the case managers start rounding, the social workers, we disseminate that information to them as quickly as possible so that they know we're trying to get this patient out of here by 11.
When you get there in the morning and everything really has been done and everything is all set in motion, we were able to discharge this patient on time, everything is set and you feel good about it. And everybody's happy.
We have something called huddle or discharge rounds. It's different per unit, what they call it. Us in this meeting are basically what the patient needs to go home, what their discharge needs are. And at that point in time, we can identify from day one what any obstacles will be for their discharge.
We have a tele-tracking board where we'll assign a patient whether or not they're if they're a VIDA for the following morning, so that anyone who is involved in that patient care, they can easily see that there's an icon there and the patient is assigned as a VIDA.
Knowing which rooms, for example, they're going to come out. Us as housekeepers, we can go ahead and take care of those rooms in a timely manner because we still have to provide them a daily cleaning in those rooms. That helps me out when they're going to leave early, so they can go ahead and take care of that room.
By having these beds ready, then we're ready for those 5 emergency cases or 10 or whatever it is. Like today is a good example of that. We have a lot of emergencies and a lot of intensive care patients that need a higher level, so we have to get those beds cleaned and move patients around.
So the initial reaction to the VIDA process was, I think, a little bit of concern and pushback from doctors and nurses, because it does seem like added work in the beginning.
It took a little while for us to actually get used to it, but they're pretty proactive with it now, I would say. Yes, at first it was very holding back, negative, but once I started educating them, they started being more involved and say, hey, if you need me, I already finished this room, so in case you get a discharge early, I'm open to help.
So anytime you develop a new process, it seems like it leaps in the air, and then we kind of start to coast. So we started doing a celebration process.
So whenever the nurses come to me and tell me that they have a patient that's a VITA, they're usually very positive and motivated that let's get this patient out first. We have little competitions between units, so if somebody gets more VITAs out, then they'll get a prize or they'll get food, which nurses always like food, so it's always a motivation.
On our floor personally, we have VITA champion doctors. We've given out a couple of certificates to the doctors that come every morning and say, let me give you your VITAs for the day. So some doctors are really on board with it. They know that if they get their patients out, their next patients coming in have a bed that much quicker.
Before, we were seeing a lot of admits right at change of shift. Terrible time to get a patient. And so we really want to get those patients from the emergency room up early into a clean room.
The length of stay has drastically reduced. We're not operating in silos anymore. We're actually looking at things globally, and our patients are much happier.
So, I mean, for VITA, it's great for patient flow because now my patient flow is flowing.
My recommendations to other hospitals that want to implement the VITA process is number one, to be patient and to understand that there are going to be challenges in the beginning. There is going to be a period of time where people are upset or angry or just kind of not into it, but that will change, and it'll change once people realize the benefit of it.
The bottleneck of a hospital really is discharges, and that's, I think, if you hone in on that, like, that is going to accelerate the rest of the processes in the hospital.
If you have a capacity problem, if you have periods where you don't have enough space to deal with the volume of ill or injured people you're asked to deal with, then you have two choices. You can build more hospital beds, which is expensive and permanent and has ongoing overhead and upkeep associated with it, or you can try to use what you already have more efficiently.
It really has saved us time, hassle, money, and then patient frustrations. So give it time, be patient with the process, let it kind of roll out hospital-wide like any other policy you would have, and your staff will eventually grow to love it and adopt it the way that we have.
There's been some really great feedback from our surgeons. Once we get the patients out early, that means less time that the patients are sitting in the PACU. So the quicker they get up to the floor, the earlier they can start their rehab. And if they start their rehab earlier, then they can discharge quickly.
When I round up patients, they seem really excited. They know they're a VITA. They're talking about how they get to go home tomorrow.
You see that they have a sense of ease kind of wash over them almost.
The thing I love most about the VITA program is seeing the patients' faces as they're rolling out.
Thank you for your good care.
And we're all waving goodbye.
We just love living La Vida Loca at Torrance Memorial.